to get to invite Dr. Tsuyoshi Konishi up to the stage. He's an associate professor in the Department of Colorectal Surgery here at MD Anderson. Really a lot of experience with management of rectal cancer and helping us to understand how ctDNA informs in the management and surveillance of these patients. So welcome. Thank you so much, Tsuyoshi.
All right. Thank you for our introduction. And okay. So I'm a colorectal surgeon, and so today's talk is on non-metastatic rectal cancer. Okay, so before starting my talk, I really want to acknowledge to these three, wonderful, colorectal surgeons, Dr. Ochiai, Dr. Desley, and Dr. Behrman. Actually, today's talk they did a lot of work on today's talk. And actually, their work is ongoing. They are publishing a lot from now. So, I would like to start from the summary of today's talk. For the next 15, 20 minutes, I'm going to talk about how the ctDNA works in the rectal cancer in the era of TNT and non-operative management. And rectal cancer care is very complex. That is very different from colon cancer. Colon cancer is quite easy, and I would say just take it and cure it from surgeon's view. So it's like my mentor in Japan said it's a vini vidi vinci. So it's really straightforward to fit the ctDNA in this context. But in rectal cancer, we have various treatment options, which I would talk on this presentation. And the sequential collection of ctDNA is clinically useful in many ways, including predicting response to neoadjuvant therapy and predicting recurrence after surgery and non-operative management. And finally, current ctDNA has limited sensitivity for local regrowth after non-operative management. That is one of the most important clinical contexts in this era, and a negative ctDNA cannot prompt de-escalation of surveillance. Okay, so here is the NCCN guidelines for rectal cancer for stage 2 and stage 3. And as you see, there are so many variable treatment listed in here, starting from radiation followed by chemotherapy, or chemotherapy followed by radiation. And also there are various chemotherapy lineups listed, and also there are some chemotherapy alone approach. So these are all approved, but there's no clear indication which treatment to use. And in MD Anderson, we basically assess the systemic risk versus local risk according to the tumor location and the radiologic finding, and meticulously discuss at MDT conference which treatment to use. I don't want to go details about our decision-making process, but you can see, starting from systemic risk and how is the tumor location, is it a high rectal cancer, low rectal cancer, then what surgery is needed if the patient wants non-operative management. According to these clinical needs, we are actually choosing upfront surgery or chemotherapy alone or TNT, but either radiotherapy first or chemotherapy first. And recently, we summarized the result of our treatment consequence for these 10 years, over 1,600 rectal cancer cases. So basically, around a quarter of the patient underwent upfront surgery, while less than 10% of the patient received the chemotherapy alone approach, mainly for the low to intermediate risk patient. And the majority, almost half of the patient, received either chemoradiotherapy or TNT. And actually, the surgery, as well as recently non-operative management, are quite a major treatment option. So these are quite a heterogeneous patient population. And this is why the evidence in the rectal cancer on the ctDNA is quite limited. And one important recent trend is non-operative management. The best scenario is if we give neoadjuvant therapy, now the tumor is gone, and after 3 years, there's still no recurrence, though the tumor is almost cured. That is the best scenario that every patient wants. But unfortunately, even after very good response on the clinical setting, up to 20% to 30% of the patient develop local regrowth. And That is very slight and a very minor slight change. So for this detection, the patient needs to come to the MD Anderson almost every 3 to 4 months for 2 years. And after that, up to 5 years, every 6 months to early catch this local regrowth. Why is that? Because once the patient develops local regrowth, the patient needs salvage surgery for not compromising the outcome. And importantly, if we leave the incomplete responders, every month of the delay of the surgery leads to worse prognosis. This is an Italian multicenter study result. So this is why we really need a good modality to early catch the local regrowth in the setting of non-operative management. That means the delay of the diagnosis leads to worse outcomes. Okay, so summarizing the challenges, clinical challenges in the rectal cancer, prediction of the recurrences, how possibly escalate or de-escalate the treatment with the recurrent evaluation. And the second challenge is diagnosis of complete response, how we can diagnose a true complete responders for successful non-operative management. And the third, surveillance after non-operative management, how to early catch and salvage a local regrowth to avoid oncologic compromise. And here, I would want to review the role of ctDNA in this context. So for a surgeon, actually this period from the neoadjuvant treatment through the perioperative period is the most important period for assessing the ctDNA, as well as a post-operative and the post-non-operative management surveillance period. And according to the consensus statement, after the resection, 4 to 8 weeks after surgical resection would be the golden time for assessing the post-operative ctDNA, while after adjuvant therapy or 2 to 8 weeks, a bit wider range of the time frame is recommended for assessing the ctDNA. And first, I want to focus on the upfront surgery. This is quite similar to the colon cancer, as you can imagine. And this is the subset analysis of upfront rectal cancer cohort in the Galaxy study in Japan. But as Dr. Morris nicely presented in the first talk, the post-operative ctDNA nicely separate the low-risk group versus high-risk group. And interestingly, as in the rectal cancer as well, although this is a retrospective observational study, in the ctDNA negative group, there's no survival benefit or difference between the patient who received adjuvant therapy versus the patient who did not receive adjuvant therapy. But when the patient had a minimal residual disease with a positive ctDNA, looks like the patient who received adjuvant therapy appear to have a better outcome. So this might raise a potential possibility that maybe ctDNA give an opportunity to escalate the adjuvant therapy in the setting of a positive ctDNA after surgery. Okay, so what about this context, chemotherapy alone approach? This is a relatively new approach, which was shown by Prospect trial. And basically, this trial showed a quite equivalent oncologic outcome of a chemotherapy alone approach compared to conventional chemoradiotherapy alone. But an important aspect is that when the tumor did not respond well to chemotherapy alone, then the patient needed escalated neoadjuvant chemoradiotherapy. And here, ctDNA could contribute to early detect the high-risk group. This is an interesting study from China. Actually, they focused on the same prospective cohort like low intermediate risk, and they collected the sequential ctDNA in their randomized trials comparing different set of the CAPOX cycles. But what they found was actually at 2 cycles of CAPOX, the good responders had the clearance of the ctDNA, and the delayed or no ctDNA clearance after 2 cycles strongly predicted poor response. And that was the only and a very significant predictor of poor response. So potentially, even after 2 cycles, the ctDNA can predict the poor responders, and we should start thinking about escalating the treatment in this chemotherapy alone low-risk patient. Okay, finally, the majority of the patient, especially in the US, receive radiotherapy or TNT. So how the ctDNA works in this context. So first, actually, this was the old study in 2020, but even in this era, before the non-operative management or the current modern ctDNA technology, the positive post-neoadjuvant therapy ctDNA was highly specific for non-responders. So basically, good response to the neoadjuvant therapy correlated with a clearance of the ctDNA. And the post-ctDNA positivity predicted the recurrence after surgery as well. And this was the data from recent data from my prior institution in Tokyo. So basically, this was actually a randomized trial compared the different neoadjuvant TNTs. One, the sandwich regimen, and one was the consolidation chemotherapy regimen. And actually, he's one of my best colleagues, and I'm really proud that he published this data. But according to this data, they did sequential ctDNA collection, and the ctDNA clearance was 100% in complete and near complete responders, suggesting, again, the ctDNA clearance was quite a good predictor of potential candidate for non-operative management. And the positive ctDNA after neoadjuvant therapy was highly specific to residual disease. And the positive ctDNA with local regrowth was only 40%, very low sensitivity, although they did only they had only 5 local regrowths because of a very short follow-up period. But what they found was actually the ctDNA appeared to be not very sensitive to detect the local regrowth. And also another their finding was post-neoadjuvant therapy and the post-surgery ctDNA predicted survival. Again, this was a prognostic in terms of the survival after TNT approach. And here, what is the data from the US? So Dr. Dasari did a multi-center retrospective study collecting, I believe, almost nearly 20 institutions and collected 220 cases with stage 2-3 rectal cancer treated with neoadjuvant therapy. And in this cohort, this really represents the current trend in US. Majority had a surgery, but also almost 1/3 of the patient had non-operative management. And what they found was post-neoadjuvant ctDNA was not very predictive of the disease-free survival, but post-surgery, that means basically in the minimal residual disease window, the ctDNA nicely separated the survival. And you can imagine in this cohort, the entire cohort include not only the non-operative management, but surgery. So there are heterogeneous mixture of the residual disease patient here. But after surgery, all the tumor is clear. And in this context, ctDNA predict the recurrence. And what about the non-operative cohort? In this non-operative cohort, the patient already had a clinically complete response. So basically the same as the surgery, no basically minimal residual disease clinically. And in this context, post-neoadjuvant treatment ctDNA nicely separated the TMA-free survival. Okay, so what is the data from MD Anderson? We recently inspected our own data who underwent the non-operative management over 300 cases. And this was a retrospective cohort. And basically, post-neoadjuvant therapy ctDNA, the first drawn ctDNA predicted the recurrence after non-operative management. But we should be a little bit careful about interpretation. So when we focus on the local regrowth, yes, if it's positive, it has a very high risk for local regrowth. But even if the first drawn ctDNA was negative, still 20% of the patient develop local regrowth. And what about distant mets? distant mets has a little bit better sensitivity, but again, ctDNA positive had a very high risk for the distant mets as well. And when we look at the entire sample, total sample over 650 ctDNA drawings, actually ctDNA was not very sensitive for local regrowth after non-operative management. Only 40% of the local regrowth was caught by ctDNA. And the ctDNA is relatively sensitive for distant metastasis, around 75%. And the specificity was, though, it's very high, well, both over 90%. And why? Actually, this represents why ctDNA was not so sensitive in our cohort, because we are, a cancer center, and doing a very meticulous follow-up and the surveillance for the non-operative management. And actually, when we look at the pathology of the salvage surgery for the local regrowth, almost majority of the patient was caught at the very early stage. So, and in the very early stage, like a T0 to T2 cancer, the rate of the ctDNA positivity was very low. While when the tumor was, local regrowth was identified with relatively advanced stage, then positivity was much higher. So this represents how it is important to combine the result of the ctDNA with a clinical assessment. In other words, the ctDNA alone would never detect the local regrowth after non-operative management. So the final question is there any possible improvement with more advanced type of ctDNA, like a tumor-informed whole genome sequencing-based ctDNA assay? There's only one study which was done at MSKCC. It was only 31 patient cohort. And interestingly, what they found was the tumor fraction was associated with a sustained complete response rate. Basically, the tumor fraction was lower than the non-operative management without local regrowth was more successful. And the other finding was this whole genome-based ctDNA provided a high sensitivity but low specificity to detect the disease recurrence. So still, there's a lot of challenges in this clinical setting. And finally, Dr. Behrman is recently working on our prospective observational study at our department, collecting sequential ctDNA in ctDNA dynamics across the treatment, clinical, radiologic, and pathologic responses, and the survival outcomes. So, and more data are coming in the next couple of years on a protocol-defined ctDNA drawing in all patients who received the neoadjuvant therapy. So summarizing my talk, sequential collection of the ctDNA is clinically useful in the rectal cancer, and the ctDNA clearance after neoadjuvant therapy predict good response. In patients who need surgery, ctDNA after surgery predict recurrence. That means in the minimal residual disease period. In patients who proceed with the non-operative management after achieving clinical complete response, ctDNA after neoadjuvant therapy predicts recurrence. And the current ctDNA has a limited sensitivity for local regrowth in the non-operative management, so that suggests the importance of the integrating ctDNA with the imaging and the clinical assessment, at least at the current available ctDNA technology. And finally, I want to thank to all my colleagues who work hard on this data, and thank you very much.